So right now, up to 60% of people who have given birth are just walking around with this hidden injury. And they've basically been told, it's just normal motherhood.
Yeah, it's really disheartening.
Right, because, like, if you broke your arm, an x-ray would immediately show that jagged white line, right? And a doctor would just fix it.
Exactly. You get a cast.
You'd get a cast, you'd get a strict timeline and a perfectly clear path to healing. But when it comes to your pelvic floor, it's like that x-ray machine is just broken.
It really is. I mean, we are looking at a diagnostic landscape that is entirely murky. It's the absolute definition of diagnostic muddy waters.
Which is so wild to me.
Right, because the symptoms of pelvic organ prolapse or pelvic floor dysfunction, they're so often invisible to the outside world.
Yeah, nobody can see it.
But for the person actually experiencing them, I mean, they're entirely life-altering. You're dealing with daily physical discomfort, a loss of basic bodily functions, and just this immense psychological weight.
All without a cast to, signal to the world that you're injured.
Exactly. You just look completely fine to everyone else.
Which leaves you caught between these two incredibly frustrating extremes. Like, on one side, you mentioned to a doctor that you're leaking when you laugh or
Yeah.
feeling this heavy, dragging sensation.
And you just get told to vaguely go do some Kegels.
Right. Just do Kegels and, accept the discomfort. But then on the other side, if the symptoms are really severe, you might be rushed straight toward a surgical intervention.
Without even being given a fair chance to just heal organically.
Which brings us to the mission of this deep dive today. We are taking all these clinical guidelines, like the NICE guidelines and physical therapy protocols, and defining exactly what a realistic recovery timeline looks like.
Specifically for pelvic floor dysfunction after childbirth or from prolapse.
Right. Before you even start considering procedures, we're going to cut through all that confusing, contradictory advice and build a really clear, evidence-based roadmap for you.
And to build that roadmap, we first have to establish what your body is actually recovering from.
The actual trauma.
Exactly. Because understanding the sheer physical trauma of what just happened is
Yeah.
the only way to grasp why, immediate aggressive rehabilitation is a bad idea.
Or jumping straight to surgery.
Right. Both are completely off the table in the beginning.
So let's look at the actual clinical stages of postpartum recovery. The initial phase is called the acute phase.
Which is really just the first 6 to 12 hours after giving birth.
Right. And the medical focus here isn't on rehab at all. It's strictly on emergencies.
Yeah, doctors are just monitoring for postpartum hemorrhage or eclampsia.
Which is that dangerously high blood pressure that can cause sudden seizures, right?
Exactly. So nobody is thinking about pelvic floor exercises in those first 12 hours.
Thank goodness. So once you clear that immediate danger zone, you enter what they call the subacute phase.
Right. And this lasts from about 24 hours postpartum up to, say, the 2 to 6 week mark.
And this is just a profound window of biological vulnerability for you.
It really is. I mean, your muscles, your nerves, your connective tissues, they are attempting this incredibly complex remodeling process to just try and change back to their pre-pregnancy state.
I always think of the pelvic floor like a specialized biological hammock.
Oh, I like that analogy.
Yeah, because its job is to hold up your bladder, your uterus, and your bowel. But during pregnancy, that hammock has been stretched tight under this heavy growing weight for 9 consecutive months.
9 months of constant tension.
And then, during delivery, the ropes holding that hammock, they don't just stretch, they actively fray.
They absolutely do. The muscle fibers tear, the connective tissues are strained, and the nerves are stretched so far that their conductive ability is actually compromised.
Which sounds painful enough, but in a lot of cases, it's significantly more severe than just fraying.
Yeah. If you experience an obstetric anal sphincter injury,
Wait, that's what they call an OASI clinically, right?
yes, an OASI,
Yeah.
the trauma there requires meticulous care. These are your 3rd or 4th degree tears.
And a 3rd-degree tear that actively rips into the anal sphincter muscle complex.
All right. And a 4th degree goes completely through that sphincter and into the anal rectal epithelium.
Which is the super delicate lining of your lower bowel.
Exactly. And there is even this rare injury called a rectal buttonhole.
Oh, wow. That sounds awful.
It is. The muscle actually remains intact, but a hole physically forms between the back passage and the vagina.
Oh my gosh. Which means, as you're recovering, you are dealing with a highly, highly complex wound environment.
You really are. You're recovering from immediate surgical repair in an operating theater. You're managing stitches, potential catheters, and, a massive risk of infection.
So that 0 to 6 weeks is purely about survival and stabilization, rest, strict hygiene, pain management.
Maybe some light breathing exercises to maintain posture, but that's it.
But here's what I don't get. If the tissue is literally still trying to close a wound and clear out inflammation, why is there this overwhelming cultural pressure on you to just bounce back?
Oh, the bounce back culture is so toxic.
Right, fit into your old jeans and hit the gym before the 6-week mark.
It's just a massive disconnect between cultural expectations and cellular biology. I mean, true tissue repair simply cannot be hurried by willpower.
You can't just wish the wound closed.
Exactly. When you tear a muscle or stretch a nerve that severely, your body has to physically lay down new cellular scaffolding.
Okay, so it's clearing out the damaged cells first.
Right. And then it starts laying down early collagen. But the thing is, that initial collagen is really weak. It's unorganized.
It's like wet cement.
Yes. Perfect. It takes weeks for the body to convert that fragile scaffolding into strong, mature connective tissue.
So attempting to rush recovery or doing high-impact exercise just disrupts that whole delicate cellular remodeling process.
You are essentially tearing down the scaffolding before the cement has dried.
Which completely explains why waiting for that 6-week OBGYN clearance is so critical. Or 8 weeks if you've had a C-section.
Right. You need that initial biological runway just to stabilize the foundation.
But then suddenly you hit that 6-week appointment, your doctor checks your stitches, says you're clear for exercise, and just sends you out the door.
And that's where the system really fails people.
Because now you're entering what the guidelines call the delayed phase, which runs from 6 weeks to 6 months.
And transitioning from pure rest to active rehab is where so many people just get totally lost.
Because the advice is usually just start doing some squeezes when you remember.
Right, which is the exact opposite of what the clinical data actually recommends.
So what should be happening during this delayed phase?
Well, the first few months postpartum are recognized as the golden window for active recovery.
Because the tissue repair is still ongoing.
Yes, but more importantly, your nervous system is highly plastic right now. It is uniquely primed to reconnect with those pelvic floor muscles.
Oh, wow. So if you ignore this window, if you just adjust to leaking when you run and accept it as your identity now, what happens?
The muscle actively detrains. The body is incredibly adaptive, so it will simply relearn new motor patterns to compensate for the dysfunction.
It just shifts the load to muscles that were never designed to carry it in the first place.
Exactly, which causes a whole cascade of other issues.
The NICE guidelines, the National Institute for Health and Care Excellence, they're very explicit about this, aren't they?
Extremely explicit. A proper non-surgical trial is not just unsupervised squeezing in your car at a red light.
Right. A fair trial means supervised pelvic floor muscle training.
Yes, and they set a very specific benchmark. For symptomatic pelvic organ prolapse or fecal incontinence, you need a minimum of 16 weeks of supervised training.
16 weeks. That is 4 solid months. And for stress or mixed urinary incontinence, it's at least 3 months.
Exactly.
Wait, 16 weeks.
Yeah.
If I'm dealing with a prolapse and I'm feeling a dragging, heavy bulge every single time I stand up, 4 months sounds like an absolute life sentence.
I completely hear that.
Are doctors just delaying care to satisfy some arbitrary insurance benchmark? Or is there an actual physiological reason I need exactly 4 months to see if a prolapse is getting better?
It is totally understandable to feel that frustration. But no, 16 weeks is not an arbitrary hurdle.
Okay, so what is the math behind it?
It's the physiological timeline dictated by how your neuromuscular system actually adapts to training.
How so?
Well, when you start supervised rehab, the first 4 to 6 weeks of strength gains aren't actually from the muscle getting bigger.
Wait, really? Then what's getting stronger?
It's purely neurological. Your brain is simply relearning how to send an electrical signal to the right motor units to get them to fire together.
So the brain is just finding the pathway again?
Precisely.
Mm-hmm.
It is mapping the route.
Mm-hmm.
It's only after that initial neurological phase that the muscle fibers themselves begin to undergo hypertrophy.
Hypertrophy. That's the biological process of physically synthesizing new proteins to thicken and strengthen the muscle fibers, right?
Right. You need the full 16 weeks to allow the brain to rewire the connection and then for the muscle to physically bulk up enough to provide structural support for your organs.
Oh, I see. You simply cannot build that kind of sustainable structural core control in just 3 weeks.
Biologically, it's just not possible.
But what happens when you are putting in the work? Right. You are fully committed to this 16-week trial, but you just aren't making progress.
Which happens.
Yeah. But the beauty of the newest clinical data is that hitting a wall doesn't mean you automatically get fast-tracked to surgery.
Not at all.
There is this entire middle ground of assisted therapies designed for when you simply cannot get those muscles to fire.
The clinical landscape has evolved dramatically to address exactly this gap.
Yeah.
Because the trauma of childbirth often creates a profound mind-muscle disconnect.
Yeah, your brain is sending the signal to lift the pelvic floor, but the tissue isn't responding.
Or worse, you are accidentally bearing down instead of lifting up.
Which would just make a prolapse worse.
Exactly. So for these patients, the guidelines recommend bridging that gap with things like biofeedback, electrical stimulation, or vaginal cones.
It's like trying to flex a muscle that has been injected with Novocaine. You know the muscle is there, you are telling it to move, but there's just zero neurological feedback.
That's a great way to put it. And biofeedback essentially bypasses that numbness.
Right. It uses surface EMG sensors placed on the muscles that display your electrical impulses on a screen.
So even if you can't feel the contraction physically in your body, you can see a graph spike on the monitor when you do it right.
That is so cool. You finally know when you are actually contracting and critically when you are fully relaxing.
That visual confirmation is everything, and it goes way beyond just building strength.
I was reading this deeply impactful study published in the journal Frontiers that looked specifically at postpartum uterine prolapse.
Oh yes, the one on early rehab and continuity of care.
Right. They provided early pelvic floor rehab combined with continuity of care, meaning patients had regular follow-ups, they used objective measurements like that electromyography to check the signals, and they had guided technique correction.
And did it change the outcomes compared to just sending them home with a generic pamphlet?
The physical improvements in muscle strength were vast, but the most crucial finding was actually psychological. This guided, continued care significantly reduced the patient's symptoms of postpartum depression.
Wow. But it makes sense.
It really does. When you have a pelvic floor disorder, the feeling of bodily betrayal, this feeling that your core is broken and out of your control, it takes a massive psychological toll.
Right. So by using technology to restore their physical agency, it actively improved their mental health.
Exactly. When you remove the guesswork, you remove the hopelessness.
Absolutely. And there are even newer tech options that do the heavy lifting for you if the nerve damage is really severe.
Like Emsella, right, which uses high-intensity focused electromagnetic technology, or HIFM.
Right. It sounds like science fiction, honestly. But the mechanism is quite straightforward.
You literally just sit fully clothed on a specialized chair, right?
Yes. And it uses magnetic fields to directly stimulate the motor neurons in your pelvic floor. It induces what we call supramaximal contractions.
Supramaximal, meaning it is forcing the muscle to contract at a level of intensity and frequency that your brain could never possibly generate on its own.
Exactly. It bypasses your brain's voluntary limits to forcefully jumpstart that motor learning and induce hypertrophy.
That is incredible. And while we're talking about physical aids, we absolutely have to talk about structural support.
Oh yes, pessaries.
Because if you are dealing with a stage 2 to stage 4 prolapse, where the internal organs have significantly descended into the vaginal canal, you need way more than just muscle training to get through your day.
You need immediate relief, and intravaginal devices like pessaries are a highly effective intervention.
I have always thought of a pessary like a highly customized sports bra for your pelvic organs.
I love that. That is a brilliant way to conceptualize it.
Thanks.
A pessary, which, comes in various shapes like a ring or a Gellhorn device, is fitted specifically to your anatomy by a doctor and placed inside the vagina.
And its sole job is to mechanically hold the prolapsing organs back up in their proper anatomical position.
That's it.
So you put it in, it provides immediate structural relief, it completely stops that heavy dragging sensation, and you can actually go for a walk.
Or do your physical therapy without feeling like your insides are falling out.
Exactly. It keeps you functional so you don't abandon your conservative treatment out of sheer frustration.
It keeps you in the game. These tools ensure that your 16-week trial is actually effective. But we do have to look at the other side of the coin.
When it's not enough.
Right. Even with the best physical therapist, even with biofeedback and a perfectly fitted pessary, some bodies just reach the absolute ceiling of what conservative care can do.
The tissue might just be too torn.
Or the ligaments are too permanently stretched to support the organs through muscle training alone. So we have to define the escalation threshold. Like, when is it time to look at surgery?
The clinical data makes it really clear that escalation is reasoned, not rushed.
Absolutely.
You should consider surgical procedures when you have given that conservative care a fair trial, but your symptoms remain functionally bothersome to your daily life.
Like if you still have difficulty completely emptying your bladder or your bowels.
Or the physical bulging is just destroying your quality of life and your sexual function. If that's the case, it is time to escalate.
Medical professionals typically evaluate this using standardized systems like the pelvic organ prolapse quantification system or the POPQ scale.
Think of the POPQ as a highly specialized ruler.
Basically, yeah.
Yeah.
Doctors use it to map exactly how far the uterus, bladder, or bowel has dropped out of place relative to a fixed 0 point in the anatomy.
So it provides an objective anatomical measurement of the prolapse.
Yes.
But looking at the clinical consensus, there is a massive gap between an objective cure on that ruler and the patient's actual subjective relief.
It is one of the most important nuances in pelvic medicine. You can have a surgical repair that looks flawlessly correct on the POPQ ruler, yet the patient still experiences chronic pelvic pain or leaking.
Oh, wow.
And conversely, a patient might have some mild anatomical dropping on the ruler, but they feel absolutely fine and have zero symptoms.
Which brings up a very practical dilemma for anyone navigating this.
Right.
Let's say a doctor uses that POPQ ruler and diagnoses you with a stage 1 prolapse. Anatomically, that is considered mild. But in your daily reality, that mild prolapse is completely ruining your life.
All you can think about.
Right. You can't run. You're constantly uncomfortable. Does the measurement on the ruler override your lived experience when you are sitting in that office asking for surgery?
The gold standard of care strongly dictates that decisions must remain symptom-led and personalized.
So your lived experience dictates the treatment.
Yes. Surgery decisions are always strongest when the objective measurements on the ruler and your subjective daily suffering are interpreted together.
That makes so much sense.
A stage 1 prolapse might not typically trigger a surgical protocol, but if it is severely compromising your bladder function or your mental health, it absolutely warrants a serious discussion about surgical escalation.
And choosing to escalate to surgery doesn't mean the 16 weeks of conservative care failed.
Not at all.
You strengthen the surrounding muscles as much as structurally possible. If you do go into surgery, your postoperative outcomes are going to be exponentially better.
Because the surgeon is operating on a much stronger, rehabilitated foundation.
Exactly. Preoperative rehabilitation is incredibly protective against future surgical failure.
It is. However, there are absolute exceptions to everything we've discussed today.
The red flags.
Yes. Clinical red flags that require immediate escalation, bypassing the 16-week waiting period entirely.
What are we looking out for?
If you experience sudden severe pain, an inability to pass urine, significant unexplained bleeding, exposed tissue that becomes ulcerated or repeated, persistent urinary tract infections.
In those cases, you do not wait. You seek immediate surgical review.
Absolutely. But assuming no red flags, there is one final massive caveat to surgical timing that the guidelines stress heavily.
Right, and it has to do with future childbearing.
This cannot be overstated.
Yep.
Pregnancy itself, regardless of whether you ultimately have a vaginal birth or a C-section, will change your pelvic floor support all over again.
Because the sheer biomechanical weight of carrying a pregnancy for 9 months puts immense prolonged downward pressure on those freshly repaired tissues.
Exactly. Because of this high risk of undoing the surgical repair, complex prolapse surgery is almost always postponed until you are entirely certain your family is complete.
Okay, let's bring this whole roadmap together. Recovery from a pelvic floor injury or prolapse is not a guessing game. It is a structured biological journey.
It really is.
It starts with honoring the sheer physical trauma your body endured, giving it that initial 0 to 6 weeks of pure rest and cellular healing.
And then it moves into a supervised 16-week minimum trial of active rehabilitation, where you are giving your brain and your muscles the physiological time they need to rebuild their connection.
And if you hit a wall during that training, you don't panic, you bridge the gap.
Right. You utilize neurological assists like biofeedback or structural supports like a pessary to ensure your rehab is actually targeting the correct areas and keeping you functional.
Finally, you only escalate to surgery based on a symptom-led review. Not because you feel pressured by a ticking clock, but because conservative care has done all it mathematically can, and your quality of life demands that next step.
The entire goal of defining this timeline is to give you back your agency.
Yes.
You shouldn't be left guessing if you're doing too much too soon or if you've waited too long to ask a doctor for more help.
Which brings me to a final thought I want to leave you with today. We noted at the very beginning that up to 60% of people experience pelvic floor dysfunction after pregnancy.
It's a staggering number,
And so many people silently adjust to the leaking, the heaviness, or the pain as, just what my body does now.
which is heartbreaking.
It is, and it begs a profound question. At what point does our cultural acceptance of normal aging or normal motherhood obscure the reality that we have historically simply undertreated women's pelvic health?
I mean, we have normalized the suffering simply because it is common, rather than treating it aggressively as a mechanical medical issue with known effective solutions.
Exactly. You do not have to live with a diminished quality of life just because everyone else in your mom's group is also living with it. Your body isn't a broken x-ray that can't be read.
It is a highly complex adaptive system.
And with the right map, it can find its way back to functional health. Thank you for joining us on this deep dive. We highly encourage you to seek out a pelvic floor physical therapist or a urogynecologist and use this roadmap to advocate for the exact care protocol you deserve.